the sake of punctuality, we can go ahead and get started. Good afternoon, everyone, and thank you for taking time out of your very busy day. My name is Kristen Rain-Schuster, and I'm with Mountain Pacific Quality Health. In partnership with the Hawaii Department of Health, Times Pharmacy, and the University of Hawaii at Hilo, I welcome you to Utilizing Pharmacists and Community Partners to Improve Care. Our guest speakers today are Roy Gu, Director of Pharmacy, Associate Professor and Chair of the Department of Pharmacy at the University of Hawaii, Hilo, Melissa Machida, Clinical Pharmacy Manager at Times Pharmacy, and Shelby Meter, Times Pharmacy Diabetes Education Coordinator. Before our speakers share their expertise, I would like to share some data around comprehensive medication management in Hawaii. Based on practice reporting to CMS, Hawaii primary care providers provide CMM in an assortment of ways. The majority of providers are utilizing external pharmacists to support CMM needs of their patients, which conveniently aligns with what we are going to talk about today. Later on in the presentation, our subject matter experts are going to talk about how patients are prioritized based on criteria as well as patient need. This data slide represents how primary care providers are opening access to CMM for their patient population. Lastly, as most of you know, refining workflow processes through quality improvement activities is a critical way to assess the effectiveness of care and to make adjustment to workflows as you and your care team see fit. Based on data from 2019, the majority of practices referenced in this data indicate they are analyzing the workflows of their care teams as it applies to CMM and utilizing pharmacists to improve the care for their patients. All of that data being said and framing our discussion today, I would like to welcome Roy Gu. Roy is going to share his knowledge and expertise in how to better utilize and integrate pharmacists into the primary care team. With that, I will turn it over to you. Roy?
Hey everyone, again, thanks for joining us. Next slide. Oh, sorry, next slide. So it shouldn't come as a big surprise that medications and medication-related issues contribute to a big burden on our healthcare system. So approximately 1/3 of adults take 5 or more medications, and this really leads to 5% of all hospitalized patients experiencing an adverse drug event. It's estimated that there's about 1.5 million of these preventable medication-related adverse events each year, resulting in somewhere around $200 billion in morbidity or mortality costs. Next slide. So when we talk about medication-related issues, it really can fall into a number of different categories. A big reason are, of course, the patient experiencing an adverse drug reaction. Nonadherence also contributes to suboptimal control. And then inadequate therapy, whether the patient being on the wrong antibiotic or a suboptimal dose of their antihypertensive or anti-diabetic drugs, account for a large proportion of these medication-related problems. Next slide. So then it makes perfect sense that a pharmacist should be able to contribute very heavily to patient care and mitigate some of these adverse events. But some of the barriers that historically have prevented pharmacists from being more involved in direct patient care include reservations about pharmacists serving in a non-dispensing capacity. Traditionally, our profession has always been thought in the context of just dispensing. However, for the past 15, 20 years, really pharmacy education has come a long way in training their graduates to make pharmacologic recommendations, provide education, and monitor and manage a patient's medication therapy. Traditionally, there's a lack of understanding regarding the relationship between prescriber and the pharmacist in the context of these medication therapy management services. And because of that variability in relationship, the variability in the level of trust and comfort, there has been a variation in the acceptance of recommendations made by pharmacists. The next slide. So really what I want to point out here is that the role of pharmacists in medication therapy management in a non-dispensing capacity is not a new one. It's really been around since the 1970s, and really became widespread throughout the VA system in the mid-90s. Today, it's used extensively in managed care organizations like the VA and Kaiser, because they've really demonstrated a benefit in terms of cost avoidance and decreased total healthcare expenditures in having a pharmacist help to manage some of these patients' chronic conditions. Furthermore, they found that it makes their physician or their provider team a lot more efficient by freeing them up to take care of more acute or more complicated issues. Next slide. So what is medication therapy management? Well, before we talk about what it is, we first want to recognize what the goals are. So the goals are first to improve interdisciplinary collaboration, to create an environment in which everyone can be practicing at the top of their license, and so that we can more efficiently use each member of the healthcare team, to enhance communication between the patient and the healthcare team, providing a accessible healthcare professional in the form of a pharmacist, to optimize medication use, and ultimately to improve patient outcomes. Next slide. So it's important to remember that medication therapy management is distinct from medication dispensing. Managing medications is not the same as simply providing education or counseling when a patient picks up a prescription, because it is patient-centered and not product-centered. So it really takes into account the patient's overall lifestyle, their comorbidities, their social and social determinants, in order to make the most efficient treatment strategy. And it empowers patients to take an active role in medication management through education, as well as compliance coaching and compliance assistance. Next slide. So one example of the benefits of medication therapy management was shown in this Minnesota experience. And prior to this, most of the studies that looked at medication therapy management were product specific. So it looked at the cost savings associated from changing a patient from a brand name statin to a generic statin, or a brand name ACE inhibitor to a generic ACE inhibitor. But this study really looked at the overall decreases in healthcare expenditures as a result of a pharmacist helping to manage and optimize a patient's medication therapy. So it looked at the clinical effects associated with medication therapy management in the form of diabetes and hypertension control. It looked at the obtainment of quality measures, in this case, the HEDIS measures, and looked at the total healthcare expenditures the year before and the year after implementing a pharmacist into the practice setting. It was a one-year study period, and was not very intensive. It at a minimum included at least one initial encounter and one follow-up encounter, again, with a pharmacist that was embedded in the clinic. Next slide. And so I really want to stress the point of the pharmacist was embedded into the clinic. Now, it doesn't have to be physically, but what is important is that the patient understands that the pharmacist is part of the care team, and that pharmacist really does not work in isolation or in silo, but really works directly with the care team. And that there is what we call a warm handoff of the physician really introducing the pharmacist, referring the patient to the pharmacist, because what we saw here is that the number one barrier that was encountered in this study was a loss of patients at the initial reach out, their initial encounter. Because they had no kind of protocol or procedure around introducing the pharmacist and doing a warm handoff, a lot of patients didn't complete that initial consultation or that initial visit. Go ahead, next slide. Here is a table of the different medication-related problems that were found in the study, and it mirrored pretty closely to what we saw in other studies and to the pie graph that I showed earlier. It's important to note here too that after the pharmacist intervention, there was a significant increase in the proportion of patients who met the quality measures, the HEDIS criteria. Next slide. And so the results of the study showed that on average, the cost of a medication therapy management cost about $266 per patient, but resulted in a cost savings somewhere around $3,000 as far as healthcare expenditures. So really there was over a 10 times return on investment when we talk about the cost of pharmacist services, related to the overall cost of care. And so again, that's a big reason why managed care companies, large healthcare organizations have been utilizing this model for quite some time. Next slide. So when you are planning to identify patients who would receive the most benefit from medication therapy management services, it's important to very specifically outline what those inclusion criteria would be. So one example is the criteria that was used in the study, and also the criteria that's used for the Medicare Part D medication therapy management benefit. And that's patients with 3 or more chronic conditions, because quite often they have issues with compliance and very complicated medication regimens, taking 8 or more Part D drugs, and then having a high total cost of drugs each year. So that would be an example of how to identify patients who would most likely benefit. But again, sorry, next slide. But another thing that you should take into consideration when trying to decide what population or what segment of your patient population you want to target is what kind of services you're looking for. And so MTM is really a broad term. It can include things like targeted medication reviews, so looking at specific diseases like hypertension or diabetes, looking at specific medications like statins or aspirin. Or it could involve patient education and disease management coaching. And really, pharmacists are kind of ideal to provide those services because, as we all know, sometimes it's not one or the other. A lot of times we can't manage these chronic diseases with just lifestyle interventions and education or with just medications. There's no magical pill that does it all. And so having a pharmacist allows them to kind of assess the patients, making sure that they are working with both arms of that at the same time. So if the patient is on the appropriate medications but need education, they don't have to refer that out to someone else. They can do that right there. If the patient has good education and is having issues with compliance, they can work on that, either lifestyle compliance, dietary compliance, or medication compliance. And perhaps there is some things that could be optimized in their medications. And again, it's a one-stop shop that can kind of be taken care of and the patient can get assistance for. And that really frees up a lot of time from the physician to focus on other things. The last kind of very comprehensive MTM model is what we call CMM, or comprehensive medication management. And so comprehensive medication management really is a holistic approach. And the reason that they came up with this was because they saw that the majority of drug therapy problems are classified as inadequate therapy. Either they have an indication that's not being treated, perhaps they're at high risk for cardiovascular disease, or their diabetes or hypertension or COPD is not being appropriately, optimally managed. And so from a standpoint where a pharmacist is working in a silo and just looking at the medication record, it's very hard to identify these types of errors because they don't have that interaction with the patient. They don't have that interaction with the medical team, and they're not privy to the medication or the medical record and the physician notes. And so all they can really do is look at possible drug interactions, identify maybe if a patient's at risk for adverse events, but they can't necessarily look at the patient as a whole and identify if the patient is receiving inadequate therapy. Next slide. So comprehensive medication management is a model that was first kind of developed in the context of the patient-centered medical home. So it's delivered directly to the patient. The pharmacist works directly with that patient, and it is both systematic and comprehensive and coordinated with the entire healthcare team. It is whole patient focused. So not just focused on the medication, but really the overall health of the patient, taking into account diet, lifestyle, and medications. And it does require a collaborative practice agreement that spells out the roles and responsibilities. For example, a collaborative practice agreement that gives the pharmacy the ability to manage and monitor the patient's diabetes and make changes in the context of that specific disease state is very commonly what we see when it comes to CPAs or collaborative practice agreements. Next slide. Okay. So the steps involved in CMM are first assessment of the patient, evaluation of the medication therapy, and then a development and initiation of a plan, followed by follow-up and monitoring. So really the same approach that other healthcare providers take when managing a patient and their chronic conditions or any other conditions. Next slide. So some key quality measures that can easily be identified and addressed through medication therapy management are listed here. And these are all your not only your medication related quality measures, but also things like education, tobacco cessation, immunization, MedRec post-discharge. And a lot of pharmacists, a lot of practices do leverage their pharmacists to help with that transitions of care piece. Next slide. And so just to look at one example, these are studies that were done looking at a pharmacist's management of hypertension. And what we found is that over a wide range of different interventions, pharmacists were able to quite significantly affect the control of the patient's blood pressure. So some of these were done in person, some of them were done over the telephone or through telemedicine. Some were very intensive, where they met with the patient every couple of weeks, some only a couple times a year. So there is a wide range of models out there that have shown benefit. Next slide. And the same for diabetes. And so I think that Times now is going to talk about kind of the model that they've developed to help provide education and medication therapy management for their diabetes, working with one of the clinics there on Oahu. Next slide. So I believe these resources will be available after the presentation. But with that, I think I will hand it off to the team at Times. Thank you, guys.
Great. Thank you so much, Roy, for that. I know there was a plethora of resources on those previous slides, but rest assured, we'll get you those resources in the slide deck to be able to utilize those for future work that you're doing within your organization. So now I would like to turn it over to Melissa Machida, who is the Clinical Pharmacy Manager with Times Pharmacy, to discuss a pilot project that she's done with a provider in Hawaii. And then we're going to go over some of the diabetes education services that are available through the Times Pharmacy. Melissa?
Hi, everyone. I'm Melissa Machida, Clinical Pharmacy Manager at Times Pharmacy. Thank you for joining us today. I wanted to talk to you about my experiences in this clinical field with Times Pharmacy. I'm very grateful to have had a wide variety of experiences and was very excited to be part of the clinical department after I graduated from pharmacy school back in 2014. I went to the University of Southern California, and our school really emphasized clinical services. As Roy was touching upon earlier in his presentation, pharmacists are really equipped to help physicians in a clinical setting because of the experiences that we have during school and thereafter. After I graduated from USC, I was part of the clinical team at Times as a clinical pharmacist. And I was introduced to a project in partnership with Times Pharmacy and UH Hilo. And this project was called Farm to Farm. During Farm to Farm, we saw patients that were discharged from various hospitals across Oahu. And I would call the patients and do medication therapy management for them. So that was a very exciting opportunity for me to connect with the patients. A project that stemmed off of that initial Farm to Farm project was to see if we could have a pharmacist in a physician's office performing comprehensive medication management. And that model was really built to allow for better collaboration between the pharmacist and the physician, and to help provide better patient outcomes. And we really want to make sure that the pharmacist can really help to assist the physician, because as we know now, physicians are being graded on various STAR measures, and pharmacists with our knowledge from school are well equipped to help you with that. So this pilot program that was an extension of the Farm to Farm program, I performed this in Dr. Kurata's office in October 2015 all the way to March 2016. during my time there, we kind of built a model where I was in a separate office within their office. I had my own room. And after Dr. Kurata saw the patients, I then saw them afterwards to go over their medications and any medication specific questions. When I was there, you know, as far as who I saw, I would see the patients that were already seeing Dr. Kurata for a wellness visit. So they were already in the mentality that they were going to have a comprehensive review of their health, both with Dr. Kurata and with myself for their medications. I would also kind of, you know, look at the list in the morning and see which patients would be the best patients for me to see out of all the visits in that day. So like Roy mentioned before with the previous the previous data, I also built my own criteria for who I would see during the visit. So I would see elderly patients, 65 years or older, who were on 5 or more chronic maintenance medications and who had multiple chronic conditions. And, you know, if Dr. Kurata notified me that he was having trouble with a particular patient in a certain area, I would also talk to that patient at that time. So yeah, this project, when I was speaking with them, I would, you know, take a look at all of their medications. I would screen them for indication, making sure each medication had a purpose, making sure each medication was effective, that it was safe for the patient to take, and if they were in fact taking that medication and being adherent to it. I also, as part of the comprehensive process, I asked them about their use of over-the-counter medications. I would document all of this, all of my discussions with the patient. I would provide any counseling that I needed to provide, education, help them to solve any medication-related problems. And I would communicate all of my findings to Dr. Kurata in a one-page PDF document and upload it to his electronic medical record in the patient's office visit note. Next slide, please. So over that time period of the pilot from October 27, 2015 to March 30, 2016, I saw a total of 226 patients seen, and 33 of those patients were seen twice. So from October to November, I had the initial patient visits, and then some I saw again between January and March of 2016. Next slide. So when I was looking at analyzing the data from this project, I made a graph of the different types of issues that were detected. So as you can see from this graph here, and this kind of ties into what Roy was saying earlier, inadequate therapy in terms of indication and untreated indication did make up a bulk of the issues that I detected. Adherence was another big issue, which I know from my experience in retail pharmacy, followed by effectiveness. Some patients had no issues, and a small population did have safety issues that we were able to assist them with. So yeah, most of the patients without issues kind of came towards the end of the pilot because they were already detected in the first 3 months of the pilot program. So they had already been seen once, so the follow-up visit didn't have any issues that I was able to detect. So as far as indications were concerned, we were looking to see if medications were appropriate or not, if there was a duplicate therapy within a medication class, like for example, 2 calcium channel blockers, or no medication purpose. Untreated indications, that would be where there was no prevention or treatment of any kind, despite documentation of the patient having a certain medical condition in their profile. As far as adherence is concerned, there are various reasons for patient adherence issues, but the most common would be the person's personal belief or choice not to take the medication. And from there, pharmacists can really help with educating the patient and changing their perspective to convince them to take their medication, or finding effective ways to remind them to take their medications if they're forgetting. As far as effectiveness issues, we want to make sure we're optimizing medications to the appropriate level for the patient to control the medical condition. Sometimes doses were too low or the drug was ineffective to treat the medical condition. As far as safety issues are concerned, Sometimes the doses were too high, so the patient was experiencing adverse effects. So that's where I would come in with a recommendation to adjust the dose or discontinue the medication and recommend an alternative. Next slide. So if we kind of drill down to the data and see exactly what went on, this is the graph for the number of indication issues and broken down by the types of issues that had occurred. So the most common indication issue that was found was unindicated medications that should have been discontinued, but were not, followed by duplicate therapy or no current indication issues. So some common examples that I did see as far as unindicated medications to be discontinued were mostly with the over-the-counter medications. I remember there was this one patient and she brought 2 whole boxes of vitamins. So I remember it was very interesting and challenging to sort through all of it to kind of decrease the amount of supplements she was taking. I'm sure we all have experiences with those types of patients as well. But there were lots of OTC medications, tons of vitamins, and she was already on a multivitamin. So it was really a process to try to convince her to, that the multivitamin is sufficient. She only needs 100% daily value of certain items, like, for example, vitamin C, and taking an extra vitamin C supplement would not really be that beneficial if her multivitamin already had 100% vitamin C contained within there. As far as duplicate therapy is concerned, there were patients, sometimes a doctor changes a medication if it's not effective, but the patient may not remember to discontinue that medication. So, there may have been examples where the patient was on 2 calcium channel blockers, like doctor told them to be on nifedipine, and then it got discontinued because it got switched to amlodipine, but the patient didn't make that connection. So I was there to kind of, read through doctor's notes and determine which one they should be on and letting the patient know which one to stop and which one to start. As far as no current indication is concerned, a common theme that I did see were proton pump inhibitors being left on their medication profile when they were hospitalized. They were taking it for perhaps a 14-day course, and they didn't have any reason to continue it beyond the hospitalization, so it was never discontinued. So that was one intervention that I was able to make during my time in Dr. Kurata's office. Next slide. As far as untreated indication issues, this is really an area where pharmacists can help and use their expertise to help out the physician. As far as what I was able to see in my data that I captured, the prevention of medical conditions, that's where we can really help out. The number of untreated indication issues to help with prevention of medical conditions was greater than those needed for the treatment of medical conditions. So for example, calcium and vitamin D to prevent osteopenia from progressing to osteoporosis. That was a common recommendation that I was able to make. A lot of people, were perhaps on an osteoporosis medication, but they weren't also taking a supplement to help strengthen their bones. Also, when I was looking at the patients with diabetes, I was trying to do a really comprehensive review. And one thing I noticed was that aspirin for cardioprotection could be added on for certain patients as appropriate. And I also really looked for immunization recommendations that I could make. I'm really passionate about immunization, so I really tried to make sure that each patient, at the time, Prevnar 13 was for 65 and older, and the recommendation was to have PPSV 23 or Pneumovax 23 1 year later. So that was a common recommendation that I was able to make. Dr. Kurata's office did have flu shots, so I was, they were very good with that aspect of immunizations, but wherever I could, I tried to make sure I was recommending immunizations. As far as treatment was concerned, commonly when patients go to a doctor's office, their blood pressure may be high due to white coat syndrome. So I was really trying to monitor the blood pressure readings that were taken in office. So I would look to see what the blood pressure reading was for that day and how it compared to previous blood pressure readings. If I noticed there were a consecutive pattern of high blood pressure readings, I would then look at the blood pressure medications to see if they were all maximized. I would also kind of talk with the patient to make sure they were taking all of them. And if that was the case and their blood pressure was still high, then I would make a recommendation to add another blood pressure medication on. So pharmacists are really instrumental in this aspect. We can really help with inadequate therapy to make sure it's adequate. Next slide. So this is the breakdown of the different types of adherence issues that we noticed. Most common was the cultural or personal belief and choice. The most common reason for non-adherence was the patient chose not to take their medications, commonly over-the-counter items like aspirin or calcium that was recommended by the prescriber, but was not, the patient wasn't given a prescription. So in those cases, there was perhaps a loss in translation where the doctor told the patient to take the medication and the patient never went out to go buy the over-the-counter medication. Part of that could be due to them not understanding the value of the therapy, and pharmacists can definitely help with that education component. Another adherence issue was the complexity of the regimen. Oftentimes when they were taking medications that had twice-a-day dosing, they would often forget that second dose. I would see this happen a lot with the inhalers. So I tried to educate them as far as that was concerned. There were administration challenges as well. So for example, a lot of people, or there were quite a few people on levothyroxine, but they were taking the calcium and vitamin D at the same time, just to take all of their medications at the same time each day. But I counseled them that the calcium and vitamin D should be taken 4 hours afterwards to increase the levothyroxine's effectiveness. The least common issue that occurred was access. Most medications are affordable for patients in terms of cost because we always offer generic medications prior to brand medications, unless there is no generic alternative for the brand medication. Next slide. Effectiveness issues. It was very common where the doses were too low versus having an ineffective drug. So when the doses were too low, that was mostly for diabetes and hypertension medications. Sometimes the patients who are on supplements like calcium and vitamin D were not taking it twice a day. So I would make that recommendation as well. As far as ineffective drugs are concerned, I noticed that metoprolol tartrate was prescribed instead of metoprolol succinate for heart failure. So I did make that recommendation when I saw it to switch from the tartrate to the succinate if the patient had heart failure. Also, I noticed combinations like clopidogrel and esomeprazole being prescribed instead of clopidogrel and pantoprazole. Pantoprazole would actually be the better PPI to prescribe in that instance because it interferes less with the clopidogrel's effectiveness. So I made that recommendation where I saw appropriate. So basically, any medication that a patient receives has potential to be effective, but we as pharmacists can really help the physician to educate the patient, make sure they understand how to take it, why they're taking it, and because of our expertise, we can really help the physicians in their office. Next slide. As far as safety issues were concerned, thankfully, there were not too many. Some patients did have hypoglycemia due to the diabetes medication being too effective, or perhaps to other factors, dizziness, and frequent urination as well. So we can help the physicians by noticing these side effects when the patients speak with us, and we can recommend appropriate alternatives if needed. Next slide. So this is a slide of the recommendations that were made to fix the issues. The blue shows the number of recommendations that were implemented, and the orange shows the ones that were not. So across the board, more recommendations were implemented than not. Going down the line, the indication recommendations were done the most, followed by adherence, untreated indication, effectiveness, and safety. So I did spend a good amount of time in Dr. Kurata's office through this pilot, and we did establish a good rapport and system for communicating with each other. So because of that trust that was established, that allowed a lot of these recommendations that I made to go through. So, hopefully a lot of physicians do see the value in having a pharmacist kind of help them out with their patients. And, I'm really hoping that in the future, we will hopefully see pharmacists in most physicians' offices. Slide. So yeah, this is just kind of the breakdown of what types of recommendations were made. So commonly for indications, the PPIs were discontinued as well as the supplements. For untreated indications, a lot of blood pressure meds were added on, or sometimes calcium or aspirin as appropriate. We educated patients for adherence on, taking the medications as prescribed. Sometimes we would recommend having bigger medications changed to smaller ones that were easier to swallow, or prescribed a higher strength of medication to decrease pill burden if the medication itself was not maximized. Effectiveness, we increased the blood pressure medications, and safety, we decreased blood pressure and diabetes medications if the patients were having side effects. Next slide. So just to touch upon really briefly where pharmacists can produce positive outcomes, there are other examples of pharmacists, being part of a medical team. At ECAHI, I was able to help out with, collaboration with the nurse practitioner and dietitian to help achieve positive outcomes for patients. I know there was one patient that I remember seeing, and she, just didn't understand the importance of taking one of her medications. But through the counseling and education that I provided her, she really understood after that conversation the importance of taking her medication, and she drastically decreased her A1C after that. So it was very impactful for me to see that such, one conversation can really change a lot for a patient's health. I was a pharmacy manager at Times Kunia, and one example of a positive outcome through a patient interaction would be there was a patient that I would always measure his blood pressure at our pharmacy every day, and he wasn't taking his medications. So through the repeated interactions that I would have with him day after day after day, eventually he understood the importance of taking both of his medications regularly. And, because of that, it just kind of shows the impact that pharmacists can have if we see patients on a regular basis, whether it be in the retail setting or even in a physician's office. Next slide. So in conclusion, we can really add a lot of value to a physician's practice through, looking for appropriate indications, making sure patients take their medications, making sure the medications are effective and that they are safe. So I really do hope in the future pharmacists can practice at the top of their license and, really help out the healthcare field through comprehensive medication reviews or medication therapy management. Thank you.
Great. Thank you so much for that comprehensive overview. A ton of great information and really awe-inspiring data as you break it down into, how many impacts and how much interface you actually had with the patients that was taken directly from the primary care provider's plate. So thank you so much for that. I would like to now pass it over to Shelby with the Times Pharmacy team to get into some of the diabetes prevention program work that they've been doing. Shelby?
Hello, everyone. I hope you all are having a wonderful day. So just to touch base on just a few diabetes education services that we provide here at Times. So first, I would like to talk about our diabetes prevention program. So this program focuses mostly on patients and education with people that have pre-diabetes, and we educate them through lifestyle change programs. We are a CDC fully recognized program, and the current programs that we use are Prevent T2 and High DPP. So Prevent T2 is an in-person program, whereas High DPP, it's an online phone application program. Patients have the convenience of learning from home or wherever they are, and there's the website in the slides right there, so you can see the website and look more into high DPP as a whole. The similarities between Prevent T2 and high DPP are they're both 1-year commitment programs, and it's through classes with high DPP, online virtual learning, lifestyle tracking, so helping patients monitor their exercise, what they eat, their weight, and through personal lifestyle coaching, we can make sure that patients will get to their goals that they want to reach, and prevention of diabetes. Next slide. So we have our diabetes self-management education program. So this focuses on patients that have diabetes and are diagnosed with diabetes. With this program, we're able to conduct it online and in person. We have a platform with GoToMeeting that we use to educate our patients if they want to do it virtually, which is what we've been doing so far with our last 3 cohorts due to COVID and making sure everyone is safe. We cover a variety of topics in our class, including these 7 healthy important topics: healthy eating, physical activity, reducing risks, monitoring, and of course we talk about medications. And our class structure is we have 1 formal class a week for 5 weeks, and it's about 2 hours a class. And before the class begins, we like to get to know our patients and make sure that we want to make our program as patient-centered as possible so they get the most out of the class that they can. So we meet individually with them one-on-one, convenient whenever is most convenient for patient. And we talk for about an hour at that time to discuss goals, go over what the class will entail, and we conduct a medication therapy management. So just making sure that everything is set and in place, and we really get to know our patients and what they want to achieve. And after our interaction, we like to make sure that the doctor knows that we are speaking with the patient and what we've talked about. So we'll, like Melissa did, conduct a 1-page write-up and fax it to the physician to just make sure that the physician knows what was discussed. So yeah, the class is overall, it's a fun program. We have roughly in each cohort that we have about 8 to 10 patients. They really enjoy that group setting and really getting to know each other, people that are just like them and really going through something that maybe they thought they were alone, but they have fellow individuals that are going through the same exact thing. And we welcome family, friends, whoever is in the care, whoever provides care and support to the patient. We welcome them with open arms just to make sure that everyone is on the same page for the patient in terms of their care. And next slide. So if the patient doesn't want to do a formal class and they want to do one-on-one, we can do one-on-one education sessions. It's really convenient and flexible in scheduling. You want to make sure that again, patient-centered, the patient feels like they are cared for, and we're doing our best job to making sure that the patient gets and achieves the goals that they want to achieve. So at this one-on-one sessions, like I was talking about in the last, with our formal program, we go over medications, personal goals. We come up with SMART plans to just make sure that the patient has a plan and sticks on track with them. And with these one-on-ones, I preferably like to meet them more than once, have follow-ups as much as needed to make sure that the patient achieves what they want to achieve. The next slide. So with insurance coverage, with DSME classes, there's Medicare Part B, HMSA Commercial, Akamai and Quest, UHA, HMAA, and with DPP, UHA, and Medicare Part B cover our programs. But if there is an insurance that one of your patients, you want to refer them or they're interested, you can contact us and we can double check and verify insurance coverage for your patients. Slide. So these are just some of the testimonials from some of our patients from our last few cohorts that we've had online. overall, they've all said that they really enjoyed the course, just learning more about diabetes as an introduction. They might not have had that formal introduction into what diabetes is, how to manage their lifestyle and the ever-changing life that they lead, and how to manage that, and being a part of a group of like-minded people, of people that are all going through the same thing so that they don't feel alone. And like I said, we welcome family, friends, because we really want to make it a safe, fun space for people to come learn and enjoy and go home with the goal of learning something and taking something to carry on through the rest of their life, and just them knowing that we are there to support them, that it's us as a part of their team, the doctors as a part of their team, and just all working, collaborating together to make sure that our patients' goals are achieved. And next slide. So this is our contact information for Melissa and myself. So if you have any questions in terms of diabetes services or services that Times Pharmacy provides, we are more than happy to help and answer any questions that you may have. And there's our website below to look more into the services that Times Pharmacy provides as well. So thank you all for listening today. And I believe we are going to open up for some questions.
Thank you, Shelby.
Great.
We have a
Thank
question
you.
from Misty Davis. It's a good question. Can anyone join, or do they also have to be a member at your pharmacy?
Anyone can join. They don't have to be a Times Pharmacy patient. Literally anyone and everyone. And yeah, their insurance plays a part into it too, but most insurances will cover the DSME. So if there's an insurance that's that needs to be double checked, yeah, you can more than verify with us. But yeah, we welcome anyone and everyone.
Thank you, Shelby. Here's another question from Lauren. Do you track outcomes from the DSME classes?
Yes. So in the first class, I get lab work. Usually I will request lab work from the doctor so that I can just monitor, but we can manage weight, we can measure weight, and we have blood pressure to monitor as well. And we have A1C monitors, so we can just double check and make sure that the patient's A1C levels and monitor it that way.
Thank you, Shelby. There's a follow-up question from Misty. Is there any cost to the member?
Depending on the insurance, most of them no cost to patients, so 100% coverage. There might be some that might have a cost, but to my knowledge right now, most insurances will be 100% covered. The ones that I listed are 100% covered.
Mahalo for that. And Christopher asks, is a provider's referral needed to enroll in these programs?
With Medicare Part B, yes. But we will just, if you want to refer, if you have a patient and you want to refer, they can, but the patient can enroll on their own. But with Medicare Part B, there needs to be a physician referral.
Thank you,
so if for example, just to touch base on that. So if a patient does approach me and they have Medicare Part B, I will usually fax the form to the physician's office, just so at least the physician knows that the patient's interested, and then there's just a little signature that I need. But yeah, that's how we can approach it as well.
Thank you, Shelby. Mahalo for chatting in your questions. Please feel free. We have the next 10 minutes to answer any more of your questions. Feel free to chat them in. Yes, Misty, we will send the presentation deck out. This is being recorded.
Shelby, I know you've been working through, as I think all of us have been, through the challenges of COVID, and you started some new cohorts at the end of last year and the beginning of this year. What has the patient's response been to kind of this new virtual setting, whereas before it was a more in-person setting?
Honestly, it's been received really well. I was a little nervous going into this transition because our patients really enjoyed the in-person experience, and to make virtual as fun for them and as a great learning for that experience for them as much as possible. That was a little nervous energy around that, just to make sure we provide the same level of care. But overall, so far, the patients that have been participating virtually, they really enjoy it. I think they participate more, to be honest. I guess the comfort of their own home allows them to feel more comfortable being virtually around others. And so far, so good. Everybody really enjoys it. And I think it's convenient for them as well.
Definitely. I would assume that kind of takes your patient-centered approach to another level when you're able to see the patients within their own home and experience some things from that part of the patient's life as well. And then one last follow-up question. I know with the in-person, we were obviously limited to patients in a specific geographic location. Would this service be open to providers across other islands as well?
Yes, yeah, we are more than happy to help and serve those on other islands. In person might be a little difficult, so virtually we are more than happy to help until COVID restrictions die down a little bit, making it less difficult to maneuver around and making it as easy as possible for patient virtually. I think, yeah, we can totally accommodate and do whatever we need to do for your patients on other islands.
As far as Times Pharmacy is concerned, we do have a location on Maui as well. So that would be an opportunity for, more in-person interactions in the future if that was needed on Maui as well.
I love that. I think I can speak for everyone, both presenting and on the line as participants. We look forward to the day where we can get back to some of this in-person work that we're doing. There's definitely a piece missing, but if we can meet the needs of the patients virtually, that's great that we've got that workaround for the time being. Thank you.
Yeah, I totally agree, Kristen. As challenging as 2020 was, it's so inspiring to hear the stories of how people just adjusted to everything that was going on. We have a comment from Christopher Chow. He says it's great to hear the communication between pharmacist and provider. Question is, how often are these updates sent from the pharmacist to the provider regarding the patients?
For our program, after every interaction we have with the patient, we will write it up and fax directly. Since we all don't share, unfortunately, an EMR that we can just type directly into, we like to do it right after the interaction with the patient. We'll fax it.
And I believe in Melissa's practice, she was dropping notes into the patient's medical record after each of her interactions as well. And that's usually I'd say if when you have a pharmacist integrated into the practice like that, that's pretty much the common practice, is that anytime that there is a reach out, whether it's just a phone call or anything, there's some sort of note that is then dropped into the EMR.
Thank you, Roy. Are there any other questions from anyone else? Or any follow-up questions? Okay, here's a question. What is a typical wait time for a patient to be enrolled in the program?
It depends. We don't like patients to be waiting terribly long, but to get enough patients to fill that 8 to 10 slot. So at longest, a few weeks, just to make sure we have enough patients enrolled to see. But if they want to do a one-on-one interaction with me, I can see them immediately whenever is most convenient for them. But for the formal class session, to find enough patients to set up a formal class, it takes a little bit more coordination, but in the time being, while the patient's waiting, I can meet with them one-on-one to just go over things with them.
Fantastic. Well, if anything pops up in the next couple of minutes, feel free to chat that in. Oh, it looks like we got another question. Joe, do you want to take that one?
We got thank yous to the panelists. Thank you for your answers.
We love that. We love thank you.
Yeah.
Perfect. Well, as you all heard, there's definitely multiple ways to incorporate the pharmacists into the care team, whether it be a fully integrated pharmacist or utilizing a resource like Times Pharmacy to support the needs of your patients. But one thing that we can all agree upon is a pharmacist is truly an intricate care team member that can definitely enhance the care of your patients while also supporting the needs of the primary care provider and reducing some of the burden and expectation that falls onto the shoulders of our very busy providers. Thank you all so much for your time today. As we mentioned at the top of this, the session will be recorded. We will also be sending out the slides for all of those references. If anything comes up and you would like to reach out to learn more information about any of the programs that were mentioned or have any additional questions for our presenters, here is all of our contact information. A post-event survey is going to go out. With that, we encourage you to provide feedback not only on the presentation itself, but also let us know if you would be interested in partnering with Times Pharmacy or learning additional information from Roy about the different methods of integrating clinical pharmacists into your practice. So with that, thank you all. Please be safe out there and have a fabulous week. Thank you.